So we will wait for 1 additional minute as participants are trickling in, and then I will do the formal introduction. Okay, let's get it started. Again, good afternoon from my side. My name is Florian Uhle. I'm the medical director at Sphingotech, and it's my pleasure to welcome you today to our scientific webinar on the topic of how to use proenkephalin in the context of delayed graft function after kidney transplant. We have a fantastic speaker on this topic, which is Dr. Christian Nußhag from the Heidelberg University Hospital. Christian is a critical care nephrologist and a transplant nephrologist who's working every day with these complex patients. And without further ado, I would like to hand over to Christian to deliver his talk, and we will have time for questions and discussion afterwards. So feel free to note down any question, post it into the chat if you have any and you are not willing to speak up. Let's make it an interactive symposium. I'm really looking forward to your talk, Christian. The stage is yours.
Hello, good evening, everyone. So I start with sharing my screen. Let's see if this works. Okay. Can you see my first slide? It's working?
Yeah, works very good. Thanks.
Okay, perfect. So hello again from my side. As Florian, thank you for the introduction. As Roy already mentioned, my name is Christian Nußhag, attending a physician intensivist at the Kidney Center at Heidelberg University Hospital in Heidelberg, Germany. I'm very excited to present you our data, our routine data, to be honest, about proenkephalin and its use to detect delayed graft function and its extent in patients after kidney transplantation. So these are my disclosures. None of them have any impact on the presented data today. So first of all, we have to define delayed graft function, and the question is that relevant? The most widely accepted definition for delayed graft function is the requirement of at least 1 renal replacement therapy or dialysis in the first week after transplantation. But of course, there are other definitions. So although this is the most widely accepted definitions, there are others. They can be dialysis-based, they can be creatinine-based, or can be a combination of both. And for example, here, this definition, the second one here, excludes, in comparison to the most widely accepted one, excludes the first 24 hours. Other definitions, or to fulfill other definitions, you require 2 or more episodes of dialysis. So this is actually implying that when you use this definition, it's a more severe DGF compared to the most widely used one. Also, when we look at creatinine, it depends either on a missing fall of creatinine or that creatinine remains above a certain level at a certain time point. What is important to note is that depending on which definition we use, the incidence is high, but ranges from 24 to even 70% of patients after kidney transplantation. This is important to know. And that also, not also the incidence differs depending on the definition, it's also the outcome. Here, the outcome graft loss within 5 years after kidney transplantation. For example, when we use the most frequent accepted definition, just 1 dialysis within the first week after transplantation, we end up with a hazard ratio of adjusted hazard ratio of 3.75 for graft loss within 5 years. When we use a more severe definition, the one with more or two or more episodes of dialysis, we of course have a higher hazard ratio for graft loss in the future. When we use creatinine-based or combination of both, we end up with 13 or 8.24. So patients are at higher risk for graft loss within 5 years, depending on the definition we use. So, but what is delayed graft function in general? And since I'm a critical care nephrologist, I like to see it as the AKI of kidney transplantation. I know that is simplified, but the most dominant contributor to DGF is ischemia time, cold and warm ischemia time. We have ischemia reperfusion injury to the kidneys. And this is why this is so a dominant factor that I like to call it the AKI of kidney transplantation. But of course, life is not that simple. We have other factors that contribute to the development of DGF. These factors can be donor related or recipient related. When we look on the donor side, for example, we have gender plays a role, but in general, factors that somehow affect organ quality. That means deceased versus living kidney donation, increased donor serum creatinine, increasing age. All of these parameters are associated with delayed graft function, but as I already mentioned, the driving contributor to DGF on the donor side is cold ischemia or warm ischemia time. When we look at the recipient side, there are also factors that are known or described to contribute to DGF. This is gender again, of course, pre-existing conditions like diabetes and a previous transplant is also associated with a higher likelihood of DGF after the second transplantation. What we also see is that somehow the immune system seems to play a role, since patients with a higher amount of human leukocyte antigen mismatches are more likely to get DGF. This probably implies that also antibodies against HLA antigens may play a role in DGF. So how does DGF affect outcomes? We know that delayed graft function is a common problem, as I've already showed you, and it is associated with prolonged hospitalization, increased risk of rejection, and also reduced quality of life. But the most, let's say, severe complication is graft loss. These two figures here above nicely show that patients with delayed graft function in red compared to patients, or the other way around, patients with no delayed graft function compared to patients with delayed graft function have a better graft survival here after 10 years. This holds true when we look at living with functioning graft and also graft survival censored for death. So graft function really, delayed graft function really affects the long-term, short-term, of course, but also long-term outcome of our kidney graft. But so far, we talked about kidney or delayed graft function as a single event. And to be honest, that's not the case. We have varying DGF severities, and it's probably even more important to classify varying DGF severities, because this is illustrated by nicely illustrated by these two figures here below. Here the authors divided DGF severity based on how long a patient required dialysis after kidney transplantation. And what you see is that patients with a very mild DGF, just 1 or 2 dialysis within the first 24 hours, they more or less have, after 10 years, the same outcome as patients with no DGF. So that means it's important to distinguish between, to identify patients with different DGF severities, especially since patients with very severe DGF with the requirement of RTs beyond the day of 14, they have a poor outcome when we look at graft survival within 10 years. So the problem that we face in clinical routine is that we, based on assumptions, based on these clinical parameters I already mentioned, we make the assumption that the patients may develop DGF, and when DGF is present, we also make assumption about how severe it is. But we know from other situations that we can be wrong. And this is an unsolved problem in clinical routine right now. At the moment, we only can detect the severity of DGF retrospectively by the use of creatinine or dialysis, or the requirement of dialysis. And even urine output, one would assume that urine output is a good marker for no DGF or DGF severity. In general, this is true, but For the individual patient, it is more complex. We have situations where the graft somehow develops a sufficient urine output to establish a volume homeostasis, but the clearance capacity of the kidney is still not enough, and we have accumulating uremic toxins leading to requirement of several more dialysis procedure, despite the fact that we have a sufficient urine output. So even urine output is not a sure predictor of DGF severity. So what is our current tool to predict or to identify patients at risk for DGF? And I mentioned that earlier, mostly clinical parameters like donor age, cold ischemia time, donor creatinine prior donation. And in this study here, the authors developed a scoring system using these clinical parameters and somehow received a good area under the curve for the prediction of delayed graft function in general of 0.73. And this was superior compared to the use of cold ischemia time alone. Another field that somehow is related or is investigating regarding delayed graft function are damage biomarkers, here in the form of total cell-free DNA in the plasma. And the authors here showed that the plasma concentration or higher plasma concentration of cell-free DNA is associated with a higher likelihood for DGF compared to patients with immediate graft function. But the problem with this is, and also with all the other damage, mostly damaged biomarkers that were already studied for the prediction of DGF, that damage is always present after kidney transplantation. That means we cannot avoid cold ischemia time. That means there is a certain amount of damage to almost all grafts. And it's no linear correlation between damage and kidney function, and especially the remaining capacity, the remaining functional capacity of the kidney that we are interested in. So we want to know how good is the remaining tissue, how good can this kidney be in the future, near future, and several months later. And so far, this is not possible with the biomarkers we have, and also not with all these damaged biomarkers, in my opinion, that were investigated. This brought us to a new biomarker, a new kidney function biomarker. This is Proenkephalin A. Proenkephalin is derived from the same precursor molecule as endogenous enkephalins. It's a very small molecule, and it is supposed to be freely filtered. So far, there is no evidence of protein binding in the circulation, and it has been shown that it is that PenKid, so short for proenkephalin, is a very early indicator of AKI. It predicts the future decline of GFR, and is also related to poor outcome in different diseases. But most important, probably, it has been shown that PenKid really correlates pretty well with gold standard measured GFR, also in non-steady state condition, and this is an advantage over creatinine. So it suggests that PenKid has a better kinetic compared to serum creatinine. This is why we looked in our transplant patients after proenkephalin with the hope that it can guide us better in clinical routine regarding delayed graft function. For this purpose, we initiated a study. So far, this is a prospective monocentric study. We included 159 patients after kidney transplantation, and PenKid plasma levels were measured in clinical routine with all the other biomarkers or with a routine blood sampling from Monday to Friday. So here you see the first results of our patients. On the left-hand side, you see PenKid compared to creatinine. On the right-hand side, longitudinal data after transplantation until day 21. So what you see is that as early as 12 to 24 hours, PenKid identifies patient with DGF compared to no DGF here in gray, DGF in white. And when we look at creatinine, we get that same signal, but 24 hours later compared to PenKid, suggesting once more that PenKid is a faster biomarker to detect DGF. But as I also mentioned, it's not only about DGF, yes or no. It's even more important to detect DGF severity. This is what we are interested about, the functional capacity of the kidney. We learned that mild DGF probably has the same outcome as no DGF, so it's very important for us to early predict or get an early estimate about the maximum DGF severity. So for this purpose, we defined DGF severity based on how long a patient was on dialysis in our cohort, mild DGF severity, moderate DGF severity, and a severe DGF severity. And here you see the results. Again, on the left-hand side, you see PenKid levels. On the right-hand side, creatinine levels. What you see once more is that patients with no DGF, they showed an immediate decline within 12 to 24 hours of PenKid, whereas the same signal was achieved on day 2 with creatinine. When we look at DGF severity, we were able to detect an improvement in functional capacity of the kidney with PenKid in patients with mild severity as early as day 6. When we look at creatinine around the same time point, there's no signal. We do not get that information with creatinine. But the initial decrease in PenKid, or the earlier decrease in PenKid, later also translated in an improvement in creatinine, but almost a week later. So much earlier, PenKid seems to be much earlier than creatinine. The same holds true for patients with moderate DGF severity. Also around day 12, we get a positive signal that kidney is improving in these patients. When we look at PenKid, no signal for creatinine, but again, the improvement that we see here also later translated in improvement of kidney function or creatinine, to be more precise, when we look at moderate DGF severity. The question that always comes to mind is how does urine output perform in comparison to DGF severity? And for this, I want to remind you that we get a different quality of information from urine output and the functional biomarkers. Because here again, during the first 3 days, you can say that urine output more or less shows us what PenKid shows us. So they are pretty much the same when we look at different DGF severities. However, when we look at the individual patient, you have to keep in mind, urine output does not mean that you have a sufficient excretion of uremic toxins. So that means we get from urine output signal, we get the information, okay, volume homeostasis is fine, and it's still a good signal that kidney function is improving, but it's not a sure case. We always needed a functional information, and we get that at the same time with proenkephalin. When we look at later days here on day 6, we see that urine output does not help us at all to differentiate between no DGF, mild, and moderate DGF, because they more or less reach the same levels of urine output. However, and this is the same for creatinine, no differentiation between these groups. But when we look at proenkephalin, we see that the function of these kidney allografts are improving here, and it's indicated by proenkephalin, and we don't get that signal with creatinine. The same holds true for day 12 to 15, comparable urine output in all our patients. No discrimination ability regarding different severities of DGF. Also not possible to distinguish moderate from severe DGF with creatinine, but we get that signal with PenKid improving proenkephalin levels, showing an improvement of functional capacity or clearance capacity in these patients. And lastly, in patients here around day 21, still no difference in urine outputs, but we have these patients with a poor graft outcome until day 21. This is identified. The risk stratification works well with PenKid. From the beginning, they have high levels, never decreased to a certain extent below a threshold of 200. This is very important threshold, in my opinion. And PenKid identified patients for high risk at any time within these 21 days. And this is also then shown with creatinine, and unfortunately, some of these patients had not a good graft outcome. In this analysis, so let's stop talking about delayed graft function. For this analysis, we divided no DGF in slow graft function and immediate graft function. For this, we used creatinine on day 0 compared to creatinine on day 7. And what we found here was that PenKid once more was able to differentiate patients with slow graft function from delayed graft function as early as 24 hours. Creatinine was not able to give us that information once more. And the same signal that we got here on day 1 is achieved with creatinine on day 6 to 8. So far we talked about absolute values. Now we talk about changes. PenKid changes. Here we compared PenKid prior transplantation with PenKid levels the day after transplantation. And by using these PenKid changes, we end up with a very good area under the curve for the prediction of DGF. And in comparison to creatinine, also the delta, the creatinine change from prior transplant to the day after, we see that the area under curve for the prediction of DGF is inferior. This was a univariate analysis. So what about multivariate analysis? Here we included all these contributors that somehow are affected, or the main drivers of delayed graft function, like cold ischemia time, urine output as an indicator of improvement of kidney function, but keep in mind, does not mean clearance capacity. Donor creatinine, deceased versus living kidney donation, duration on dialysis prior donation, and donor age. And we see that in this multivariate model, PenKid is still the strongest predictor for delayed graft function, once more showing that PenKid seems to have additive diagnostic information compared to all the standard parameters that we use at the moment. So now I've shown you a lot of box plots and AUC analysis. Let's finish with some cases from our clinical routines or hands-on on PenKid. And first of all, you want to start with a good example. So this is a patient with a primary graft function. We see an immediate decline in PenKid levels and also creatinine levels, so they match very well. But when you look more in detail, you see that PenKid somehow gets to the bottom levels to its baseline earlier than creatinine does, once more showing earlier that this kidney function will be excellent at discharge. And this was the case with the creatinine of 1.74. Another example, same picture, also a patient with primary graft function, good transplant outcome, immediate decline of creatinine, and PenKid. PenKid was a bit earlier in reaching its baseline level than creatinine. So these cases are probably more interesting because they deal with the fact that we have struggled to identify patients with DGF, and especially the severity of DGF, because we have patients with DGF and good graft outcome and patients with DGF and poor graft outcome. In this case, the patient more or less in the end had a good graft outcome with a creatinine at discharge of 1.3. But in the beginning, the patient suffered from a severe delayed graft function. These initial drops in creatinine are induced by hemodialysis procedures. And at the end of the last RT procedure, we saw a rise again in creatinine, and this is always when you as a nephrologist or a surgeon, you feel uncomfortable, you think, what is the problem of this patient? So you exclude all the surgical problems, you perform ultrasound, the perfusion is great, tacrolimus doses is great. And then you always think about, is there, although it's unlikely, an early rejection? Shall we perform a biopsy? And all these questions, we had all these questions in that patient, but PenKid was able to give us a positive signal from the beginning that the functioning capacity is actually improving the whole time. So giving us a positive signal that there is actually no issue. It's probably ischemia, reperfusion, injury. And in the end, we have a great outcome that was already indicated by PenKid from the beginning, and we were distracted by creatinine because it was rising up to a very high level of 9.3. Same situation, other patient, once more a good graft outcome or transplantation outcome at discharge. But in the beginning, severe delayed graft function several times, hemodialysis, again, rise after the last hemodialysis, and then a later decrease in creatinine that makes you happy as a nephrologist, because we see that the functional capacity is really improving, but with PenKid, we get that signal much earlier. So what have we learned from these patterns? Right now, I would say we initiate dialysis later, and in a lot of cases, we avoid it at all. Like you see in this case, this patient more or less had the same parameters, same levels as the two patients before, but we got the positive signal of PenKid indicating a good outcome, and we waited very long until the creatinine decreased by itself. So here I've shown you that PenKid can detect DGF and also DGF severity with a good graft outcome. Unfortunately, sometimes we have a poor outcome after transplantation, and this was the case in this patient. Also very severe delayed graft function, and this here seems like PenKid is decreasing. But what I want to point out that we still have very high levels, around 400 to 500. So the patient never reached any levels near 200 or below 200, indicating from the beginning that this patient had the same creatinine levels as the other ones, same amount of urine output as the other ones. But here, unfortunately, PenKid showed us very early that this patient has a problem, and probably it's likely that we can solve that issue for this patient. So this brings me to the end of my presentation. I've shown you that PenKid predicts DGF as early as 24 hours after kidney transplantation. It allows the prediction of future transplantation outcome regarding DGF severity. This is very important, probably even more important than the prediction of DGF itself. It is able to differentiate between DGF and slow graft function, and also very important, it provides additional information about functional or clearance capacity of the kidney compared to the volume information that we get with the urine output. Changes are indeed the most valuable indicators to predict DGF compared to all the standard parameters that we currently use or are available. And this in total is the reason why we think that PenKid really helps to guide us in these patients, can identify individual risk profiles, and may therefore be of great value for patient care and also for future study designs in terms of risk stratification. I want to thank everyone who participated and supported this project, and I'm happy to take questions. Thank you.
Thanks a lot for this fantastic talk, Christian. I'm not sure if we are back already in the full vision that we see. If you see me, here I see myself. Okay, so there's one question from the chat. are there any specific patient factors or coexisting conditions that you have found or you have realized that might have impact on the reliability of PenKid to predict DGF?
To be honest, not that we know of. So far, we haven't identified any confounders. Even that's funny, I haven't mentioned that, is that somehow renal replacement therapies do not affect PenKid levels. We're not sure why this is the case, but we're looking at it. And so that PenKid even gives us an information about functional capacity under renal replacement therapy. We have seen that in other cohorts, like in ICU cohorts on continuous renal replacement therapy. So it gives us even an information under renal replacement therapy. And also when we talk about underlying conditions, drugs, so far we haven't identified any aspects or confounders that influence PenKid levels. I also have to say about this, I mean, patients after kidney transplantation, they mainly have one problem, a non-functioning kidney. Otherwise, they are more or less healthy, but they are stable, not critically ill. So we just have the problem more or less with the kidney, with a non-functioning kidney, and we integrate a new kidney, a new functioning kidney. And this is why it makes it easier to somehow understand a biomarker that targets kidney function.
Yeah, makes sense. So the second question is about other biomarkers. You obviously showed diuresis, you showed creatinine. Have you experienced any other biomarkers which are currently in the loop? Have you used other biomarkers for this specific use case?
So, I mean, there's this whole field I already mentioned about damage biomarkers, and I think they have a certain value in terms of how big the damage is. But it depends on several aspects. When do you measure it? Is it in the early phase? In the early phase, you always have a certain amount of damage. Then when you look at the studies, the area under the curve, the performance differs from study to study. This also depends, of course, on the definition of DGF, because the DGF definition itself varies from study to study. And in the end, you have very poor area under the curves, from very poor diagnostic accuracy to very high diagnostic accuracy. But the problem that I see, I mean, they have also additional information, but the problem that I see, they do not allow us to get an idea about the function of the remaining kidney. They just show us there's damage. But how good the remaining kidney is, we don't know that. And this is especially difficult when you keep in mind that the donor quality also differs. It's not that we always have a perfect kidney graft. So also the quality of the kidney differs from donation to donation. And so these damage biomarkers do not help us to get an idea about that remaining functional capacity.
Okay, makes much sense. Especially in the context of what you mentioned, that these patients are more or less healthy with low load of comorbidities. I would like to dive a bit into the last part of your presentation, where you nicely showed the different cases. Because at the end, you're a physician, you treat such patients every day, or you at least hope not to treat them. So, but you use this tool of Proenkephalin. Could you briefly explain how you use it currently? So after this results, so how is it used now? You mentioned the delta approach, going from baseline to day one, but you also mentioned the absolute values. Maybe you can reflect a bit on these.
Yeah, of course. So so far after these first results, we were pretty excited about this biomarker, and we decided to implement it in our clinical routine. And currently we measure it in all our patients within the first 7 days. And then we decide on a day-to-day basis if we prolong the measurement, because when we already see that, for example, creatinine is decreasing with PenKid, usually in these cases, we do not have a problem. But when creatinine is still rising, we're not sure where the disease course or DGF course goes. We sometimes prolong the measurement of PenKid. And I especially look at the kinetics of proenkephalin on a longer perspective within the first 7 days. And in the beginning, what I also look is, especially in the beginning, is the change from day 0 to day 1. Because this initial change in most cases show you very early that you do not have a problem at all. And this is how we currently use it. And of course, it's a new biomarker. I gained so far more experience with it. I also discuss it a lot with my colleagues and say, hey, this is like this, and show this is that pattern. And so it's an open discussion at our center, but everyone is more and more convinced that we can use it as a guiding tool in our patients, because it has consequences, right? You have to say, I do not perform a biopsy, for example, and that's not easy to do when you're not sure. And this is also because sometimes we're still analyzing it, and sometimes we still perform the biopsy, although to get a double check if this is true. But it turns out even more often that this is the case, that we don't find anything in patients in the biopsies where we have a decreasing proenkephalin, or we find something that we can treat. For example, ischemia reperfusion can't be treated. For us, it's always important to know, is there some sort of rejection or not?
Okay. Yeah, in terms of the consequences for clinical actions, you mentioned especially this very early stage within 24 hours. So could you describe a bit what happens if a patient is a non-lowering proenkephalin patient? So what is the machinery then going? How do you use it? What is the trigger? What is the consequence of this?
So I mean, when we see that there's not a sufficient decrease, that this always triggers, or I have to start differently. So usually when you don't see a decrease, a non-sufficient urine output, or a not sufficient decrease in creatinine, you start everything with, is there a surgical complication? Do you perform ultrasound? What about perfusion? And now it's let's say a two-way step process. So we have creatinine. Creatinine is rising. When PenKid decreases, we are relaxed, although creatinine is rising.
Mm-hmm. But
when both are rising, then we are very concerned. And then we somehow start all the machinery with perfusion, drug interaction, surgical complications, urinoma, all these different things, and you're more relaxed when you see an immediate decline in PenKid, especially in the first 24 hours. Then usually there isn't a problem as far as our experience goes.
Okay. So what you describe is basically an additional value, true addition, no replacement of a current standard of care, but implanting an additional diagnostic tool into this whole portfolio, what you anyhow have in the clinical setting. Okay.
Correct.
So I'm asking into the participant round. Are there any questions? If not, I would end this session with the last, maybe a little bit more forward-looking question. So you mentioned the dialysis and PenKid. Do you have any experience about the behavior of PenKid in dialysis and acute dialysis especially? You mentioned that it seems to be untouched in this procedure.
Yeah. We just presented this also at the ASA meeting in Philadelphia. It is the observation that we made was that PenKid, and this is really interesting because it's a small molecule with no protein binding, you wouldn't expect this, seems to be not influenced by renal replacement therapy techniques. Also, when you have a longitudinal continuous renal replacement therapy, Why this is the case, we don't know this yet. Probably it could be a very high regeneration rate, but because you would assume that you clear PenKid with renal replacement therapies. But the funny pattern that we observed is that somehow PenKid behaves independent of renal replacement therapy under renal replacement therapy, so independent. And it seems like that so patients with lower PenKid levels more likely, or in these patients, the liberation trial is more likely successful than in patients with very high PenKid levels under renal replacement therapy. So the idea is that perhaps in the future, we're still looking into this. PenKid may help us to unify standard of care regarding liberation from renal replacement therapy, or to get an idea about the kidney function under renal replacement therapy, because we do not get that with creatinine so far, because creatinine is cleared, so we're blind. And even urine output, we also, the current best parameter probably for a liberation trial, it seems to, in our analysis so far, it seems that also PenKid might be earlier or has additive diagnostic value together with urine output.
Okay, thank you. Very interesting first experience. I think this needs to be fleshed out more, but quite promising avenue also for this biomarker. If there are no further questions, let me thank you again. Wonderful talk. I think everyone enjoyed it, seeing this data. We're looking forward to seeing it published soon as well, hopefully. Fingers crossed. It's a wonderful cohort. I wish everyone a wonderful afternoon. Have a nice weekend when it's time for this, and yeah, stay safe. Bye-bye.
From Heidelberg.